All right, everybody, welcome back to Psychiatric News Special Report podcast. I am the host for today. My name is Dr. Sulman Aziz Mirza, triple board certified adult psychiatry, child adolescent psychiatry, and addiction medicine, working in Northern Virginia with Inova Health System and also my own private practice. My second month kind of hosting the special report. So we're going along with it, and I think it's been okay so far. Let us know if there's anything that we need to be doing different, and we will definitely make sure to incorporate that as much as we can. So this month we are doing a little something different. We have Dr. James Bourgeois here with us today. He is not the author of our special report. He's kind of filling in for the authors who were unable to make it with us today. The special report for February was Barriers to Rehabilitation After Discharge, a consultation liaison perspective. So basically a review of CL psychiatry, consult liaison psychiatry, and we have Dr. Bourgeois here as our fill-in. So I'll let him introduce himself and a little bit of his bio and background, and then we'll kind of jump on into a discussion.
Thank you. I'm Jim Bourgeois. I'm Vice Chair of Hospital Psychiatry Services at University California, Davis, which is in Sacramento. Um, I'm a professor in the department. I am certified in both general psychiatry and CL psychiatry. My role for the APA is I'm the CL section editor for Psychiatric News, meaning I accumulate submissions and curate them and work with the editor-in-chief on publications.
Awesome. All right. So a little review of this article. So the authors are Bucic et al. And article talks about psychorehabilitation, why it fails after discharge, particularly for patients with severe, serious mental illness, despite clinical stabilization in an inpatient stay. So the discussion is around CL psychiatry, what discharge means for a medically hospitalized patient, why this can be a little bit complicated for patients with a psychiatric history. What are some of the barriers that are there? The article focuses on three main barriers that are identified: systemic structural barriers, clinical barriers, four barriers, sorry, patient related barriers, and then social and cultural barriers.
Mhm.
And, the role of CL psychiatry as a whole. So, what do you think about that, Dr. Bourgeois? Like, are these some of the barriers that you're seeing in your work as a CL psychiatrist?
Certainly, and I suspect that's a generally common experience.
Yeah.
Uh, this article was actually sort of unsolicited. I was very pleased to get it because this sort of approach is rarely taken. Usually, the articles submitted are more patient care focused about an unusual illness or something about the clinical care that we need to give, which of course is the emphasis. This is different. This is about once patient is done with implicitly medical hospitalization, um, what happens to them and then they're transitioned back to outpatient care. And I want to emphasize that in the draft in this article, they're focusing on patients with serious chronic mental illness, which is
Yeah.
actually a minority of patients we see in hospital. So these would be patients with chronic schizophrenia, bipolar disorder, recurrent major depression. I think we all kind of collectively agree on the definition. And when these folks are admitted to the general hospital, of course, it's for a wide variety of things. But the discharge readiness decision is really made solely by the medical surgical service admitting them. Um, and as many of us in background in CNL will relate to, these decisions for discharge are kind of rigidly based on functional status vis-a-vis the admitting illness.
Right.
And there is no mechanism to mitigate that discharge date because of the comorbid psychiatric illness. Whereas if a patient's admitted to a psychiatric inpatient unit, of course, it's all about that. So
Right.
that dilemma would really not happen. So that was the broader context. And I think what we're kind of getting at here, which the authors really illustrate nicely, is that you have sort of readiness for discharge from a general medical stability perspective. That may or may not mean you're ready to discharge from a psychiatric stability perspective. And this,
Yeah.
since those are discordant, that's the source of the difficulty. Now, the reflexive response to that dilemma, in many cases, is to say, well, if the patient is psychiatrically unstable despite being physically improved, well, it's rather clear they should be evaluated for admission to an inpatient psychiatry unit for management of the second problem. And that's intuitive but limited. The main reason
Yeah.
for that is the psychiatric inpatient units have extremely limited medical and, frankly, nursing capacity. So things I see on a daily, if not hourly basis, that limits transfer to psychiatric inpatient units when it would be clinically appropriate are mobility problems, patient requires a walker, patient requires wound care, somewhat complex diabetic self-management, and on and on. And the medical and, more importantly, nursing care at psychiatric inpatient units does not allow for that, and thus those patients cannot be transferred to psychiatry, even though it would be clinically desirable. So that's the source of the dilemma in many cases.
I think for psychiatrists and people in the field, they're able to very easily like point out like why those barriers exist, why it is complicated for somebody who's on a walker to get admitted to psych floor, but for like maybe non-psychiatrists who may be listening, what are some reasons that may be less immediately apparent?
Well, again, the concern that is stated by the psychiatry units is the walker interferes with nursing routines. The walker could be used as a weapon for the patient to hit another patient or a staff member, and
Yeah.
their own internal safety regulations are kind of rigid, understandably, about that. Where to the medical units, that's not relatable because they see patients with walkers all the time. So they say, "What's the problem?" And that's
Yeah.
where you end up a lot of the time.
Yeah. It's complicated because I think there is this idea of like what psychiatry is and what medicine is, and these things are for some reason separated, even though they're being housed in the same hospital building and they should be treated the same. But it's like there are unique qualities of each one that, and unique challenges and unique opportunities, I guess you could say, that make them unique in their own way. Let's talk a little bit about systemic barriers. So, you said I had the benefit when during my training over at VCU to work under Dr. James Levinson.
Yes,
Yeah, who's wrote the book. He's
yes,
one of the
he's a
guys who wrote the
very
book.
highly regarded senior leader in CL psychiatry. I quite agree.
Yeah, so it was a great blessing to like work under him for a bit. We also had like Dr. Sharif McGee and Dr. Chris Koga. It's a wonderful CL psychiatrist. I think that was one of the strong points of being over there was like again wonderful mentors over there. Um, so I always appreciated the field, and then as I'm doing more kind of outpatient work, I've not doing much of that nowadays. We don't have to do hospital coverage as much nowadays, so we get a little siloed out in the world.
Mm-hmm.
But
Mm-hmm.
every once in a while we're on call and we have to kind of run into the
Mm-hmm.
hospital and be like, oh, here we are again. Um, but what are some overall kind of like systemic structural? We'll break them down each one by one, I guess. So systemic and
Sure.
structural barriers. What are some ones that you commonly kind of come across that maybe we didn't talk about already?
In terms of what boundary, like handing a patient off to outpatient care, or what exactly do you mean in detail?
Yeah. So the main things that they were looking at is again the what the author is saying is hospitals are optimized for stabilization,
Right.
non-continuity of psychiatric care. So
Correct.
making that structural mismatch per se. So maybe things like trouble between hospital services, community services, not involving CL early
Mm-hmm.
enough, or
Mm-hmm.
maybe inappropriate kind of
Right.
consultations. Yeah, so something
Oh,
along those lines.
I
Yeah.
could go on and on about that one sentence, but there's numerous
Yeah.
components to what you just said. So if I can separate them out a little bit.
Hmm.
Um, One is kind of a point I made earlier is that medical surgical discharge readiness is often rather concretely described. Once patient doesn't need certain medical nursing intervention, they are to be discharged. And one can, of course, one can resist that, but at the same time, you have to appreciate the demands on hospitals right now. I just got a message from my ED colleagues yesterday that they have a 100-bed capacity with only 344 patients in it. So these things are accentuated very reasonably. And
Yeah.
thus, I think to make your main approach to lobby for longer inpatient stays just to consolidate outpatient plans, that's seen as a non-starter most places, and I fully appreciate that. To that end, what has been shown in some sort of semi-prospective studies is that if you can identify what the term is cliche, but it's high-risk patients. If you can
Yeah.
identify high-risk patients sort of preemptively, you know, day of admission or the day after, somehow one flags significant psychiatric comorbidity. What really should happen in a optimized environment is the admitting medical surgical services should identify that quickly and call for consultation right away, uh, not wait until discharge is imminent. Numerous reasons for that. One is most obviously is we can be involved in medical co-management of the patient throughout hospitalization.
Yeah.
Of course, they need to be daily adjustments and so forth. That's a detail. But while you're doing that, the discharge mechanism of this medical surgical service can be mobilized far earlier, knowing particular patient's going to need a particularly designed discharge plan, rather than waiting till the last minute and expecting you to accomplish this all in one day, or sometimes it's on a weekend and so forth. So you can see the inefficiency of that. So
Yeah.
another system to be kind of aware of is called proactive psychiatric consultation. That takes this model to a slightly higher level, and it's a very desirable model. What this means is that this intimate involvement of the CL psychiatrists as sort of teammates of the medical surgical services. And they're
Right.
involved in the surveillance of what the admissions are with predictions of who's going to need psychiatric co-management and sort of encouraging the consultation earlier, as opposed
Yeah.
to waiting till the home team ascertains that and then call us. So I would be happy if people just called us in an early way to get this going. The highest level of this would be proactive, which there's a literature on that, and it's quite clear that it helps to decrease overall length of stay, get patients out sooner, which is, I think, what we all have a goal here.
Yeah. Pivoting like a little bit, one of the things when I was reading this article, and one of the things I always found really interesting with the field as a whole is from the historical aspect of the biopsychosocial model, right?
Hmm.
And from my understanding, it was George Engel, University of
Hmm.
Rochester, who's attributed with the being the founder, I guess, of this idea or mindset, which is, I think, a lot of psychiatric training is based on this. A lot of formulation is based on the biopsychosocial slash spiritual model that's out there. And again, a little story, and again, correct me if I'm wrong, but it was he's an internist and he's seeing that like we're admitting people, then treating them in the hospital, then sending them out, and then they're getting readmitted, and we're for surgical reasons or for medical reasons, and they're saying what's going on, what's happening, what's the situation, why are these patients keep coming back to us despite us doing everything in the hospital that we're supposed
Hmm.
to do, and which led to the whole idea of like, oh wait, we have to look at what's going on in their lives and in their patients' lives and when they go home, when they leave the hospital, right?
Yeah, since you mentioned Engel, who I never met, he's from
Yeah.
some decades ago, but I always,
Yeah.
whenever he's mentioned, I always remind people that 18 years before he wrote the biopsychosocial model, he wrote the definitive paper on the physiology of delirium. So,
Hmm.
so in the CL world, that's rather well known, though not universally known.
Yeah.
So, what that's about, of course, is integrating the various elements of the patient's illness and experience into a sort of a, if you will, holistic care model, so that all these elements are taken care of. Because I don't know what others' experience is, but I will say that the vast majority of discharge problems are not clinical at all. They are social.
Hmm.
Patients homeless, patients do not maybe they have a place to live, but they don't have the in-home supports because now they're hemiplegic and can't get around. And I could go on and on about that.
Yeah.
Whereas the acute care hospital operates in a dichotomous way. Do you need to be in the hospital or do you not? Which doesn't take into account the frequent inadequacy of post-hospital systems, be it rehab units, be it home with assistance, be it somebody to call them a patient, all those things. And the discharge planners are often have to kind of after the fact kind of put that together. And the other point you sort of made, perhaps inadvertently, is when you apply the biopsychosocial model, that very quickly identifies what we call the complex patients.
Right.
These are patients who are the um, top 1 or 2% in medical utilization, multiple, probably unnecessary trips to the emergency room, admissions to hospital, longer length of stay, and all that. When that has been studied, those patients have a 100% risk of psychiatric illness, be it substance abuse, chronic schizophrenia, dementia, whatever it is. So it's not much of a stretch to say that psychiatry should be involved in every complex patient, even if for no other reason than just to sort it out and try to direct what kind of services the patient needs, as opposed to try to expediently discharge them for the inevitable return to repeat the same process.
Yeah. How do we, and this, again, like ideally, if I'm hearing you correctly, we have some psychiatric worker, caseworker, or
Hmm.
social worker who's triaging every case that comes into the hospital to some
Hmm.
extent. How do we scale that when we know that we have such a huge shortage in healthcare work, psychiatric, mental health
Hmm.
workers? I will share with people that I'm, like I'm married to a nurse. She is a director of neurosurgery at the hospital. Their hospital system is like a
Hmm.
1,000+ bed hospital.
Right.
I oftentimes get to hear their meetings while she's working from home, overhear them, and they, we
Right.
invariably hear about like the patients with psychiatric conditions and how
Right.
they're a challenge to kind of get it in and out. And, if they're getting prepped for back,
Hmm.
these big, massive back surgeries or
Yep.
nurseries that are there. But like, how do we scale it so that everybody's getting some eyes on them reasonably? Yeah.
Well, of course, that's a great rhetorical question, right?
Yeah.
Well, I think there's some. Uh, I never know if I should be optimistic about this or not, but there's some room for optimism. And the reason I'm saying it that way is that now that EMRs are universal and people love to complain about EMRs, except you can't live without them. So EMRs
Yeah.
are, we should embrace them fully. And the real advantage of EMRs beyond the individual patient care is macro data management. If you are skilled at this or have colleagues who can do this for you, you can almost immediately identify the um, ultra high utilizers.
Yeah.
So when I was at UCSF for 5 years, we did just that. So we would flag ultra high utilizers. I can't remember how we defined it, but it was unequivocal. It was like, 4 emergency room presentations in a month or something like that. And even if the patient was not acutely hospitalized right then, we would meet in a multidisciplinary team, including senior geriatric physician, myself, clinical pharmacist, I think 3 social workers, and nurses, and people who were sort of not professionally trained, but we train them up and define them as care navigators.
Yeah.
So they would be given a cohort of patients to sort of look after and keep track of how they're doing and provide logistical support. Basically, what we wanted them to do, which sounds a little paradoxical, but it's very successful. What you want these patients using a whole lot of primary care, way more
Right.
than typical, because if they're doing that, they're not in the hospital. And we were able to show with this intervention quite routinely within 3 months of this team's coming online, the patient stopped the ultra utilizing behavior. We were then
Yeah.
open to the new cohort of upper utilizers. So to receive this, what you need is what I would call empathically attuned and supported primary care.
Right.
So be that an internist, family medicine, a clinical nurse practitioner, it doesn't really matter that much. But someone who is attuned to the fact that the psychiatric comorbidity is part of the picture and
Yeah.
have ready access to psychiatric consultation outpatient as needed. And you try to take the inpatient multidisciplinary model and move it to outpatient. I think that's the next step if we could universally apply that kind of thinking. So that's what I would hope other places could consider.
Yeah, no, my again, like my wife was, I think part of her return was doing care navigation, right? And that
Mhm,
was a
mhm.
lot of the coordination that's involved, especially for these, again, overhearing this stuff is, these patients are very complex in regards to, if you're getting a massive surgery, like a back surgery or such something like that, like it is a massive, it's not just you're in the hospital for a few days and you're all cured. Like, no, there's everything that comes along with it afterwards. And then of course, if you gonna factor in things like depression, schizophrenia, bipolar disorder,
Right.
this with that just complicates it further.
I think your example is a good one because what we need to be the modal care model is we need perhaps even extended PM&R inpatient units
Yeah,
with active psychiatric co-management. That is not as common as one would think. I mean,
yeah,
the examples are legion. You know, the great epidemic that no one ever talks about is traumatic brain injury.
yeah,
The suffering and traumatic brain injury down the road is something like 90% psychiatric.
yeah,
But care models, unfortunately, sort of define themselves out of that. The community mental health model doesn't consider TBI to be a psychiatric illness when it is 90% a psychiatric illness.
yeah,
The community mental health model doesn't want to own dementia, even though the vast majority of problems in dementia are behavioral.
yeah,
So I think the psychiatric sector needs to broaden its sense of what the patients are and be very actively involved in embracing and seeking those patients.
yeah. So that's is a nice little segue to like CL psychiatry as a whole.
Mhm.
What is it about CL psychiatry that how they see problems unique about them that maybe other teams may miss, whether that's inpatient psych teams, medical teams? What is unique about the field?
Yeah. Well, to me, there's a lot unique about it, which is why I find it attractive and why I've been doing it for what,
Yeah,
nearly 30 years now. Um, it's a different role,
yeah,
and many of our colleagues, psychiatry colleagues, don't embrace the role. And what I mean by that is your role, you're never the main leader, you're the consultant to the main leader.
right,
And you have to kind of, accept that and work within that. Secondly, the systemic medical surgical illness is always the number one problem,
right,
at least acutely. So your role is to ascertain the comorbid CNS illness that impacts the experience of the main illness and sort of, if you will, chip away a bit and manage that as a separate component and weave that care into the overall management of the patient so that those uh, comorbidities are not, let's say, de-emphasized compared to what they should be. And then there's a presence at the discharge exercise, assuming the patient needs ongoing care. Not everyone does, most do. To somehow make your system work to be sure the psychiatric outpatient management is part of the plan. Now, in some cases, that can be effectively accomplished by primary care once they're directed what to do.
right,
So the other piece I would add here, Sulman, is the highly desirable model of embedded psychiatric care in primary care. There's the collaborative care model, University of Washington. Many folks know about them. We at Davis we're not as um, thorough as they are, but we do a similar thing here where we have, I don't know, a couple dozen primary care clinics with psychiatric assets in the primary care clinics.
Yeah.
So that makes a very desirable handoff because the patient needs primary care anyway. So you say when you get to primary care, engage the psychiatric resources in primary care and pick it up from here. Now that works pretty well because we're all in the same EMR system. So they can look up any charting they need to get them started with outpatient care. Now, if that were to be done all the time, you can
Mhm.
see the benefit of that.
Yeah. We have, again, over here in Virginia, and especially for pediatric patients, again, like we know psychiatrists, adult psychiatrists as a whole, there's a massive shortage. We know that child and adolescent psychiatrists, there's an even greater shortage. And, again, that's part of the reason that I have pediatric residents with the
Hmm.
hospital rotating with me as they do their rotation with me is to train them up. And then one program we have here is something called VMAP, which is essentially a model of the embedded care, but more so in regards to like a warm line or a hotline where primary care docs can call in to be like, hey, here is a situation. I'm not super familiar with psychiatric stuff. What do I
Hmm.
do? Which is a nice model if you don't have that, the NPPA or a
Hmm.
doc that's
Hmm.
in the primary care clinic that's available to them. So you see tremendous kind of benefits with that collaboration that's there.
Yeah, thanks for mentioning it in those terms. I mean,
Yeah.
often the colloquialism curbsiding is used for what
Yeah.
you describe.
Yeah.
And at UCSF, we actually did that, and it was actually independent of the complex care theme I discussed. This was done exclusively between the psychiatry department CNL group and numerous internal medicine outpatient clinics.
Mhm.
So the way it worked was the patient had to be enrolled with internal medicine as the PCP, and
Yeah.
it had to be in our system. So if those criteria were both fulfilled, then the PCP could, or actually was encouraged to e-consult us, meaning send a secure email describing the condition, identify the patient, and can we offer sort of hands-off advice on what to do in such a circumstance?
Yeah.
And the CL team would rotate. I think it was once a week. We would take this as a side duty and watch these messages. And we found after, I don't know, relatively short amount of time, um, 90% of the questions could be handled by a chart review and direction, meaning you're avoiding 90% of the consultations to physically come to the clinic.
Yeah.
So you can imagine if you scale that up to the appropriate size, that kind of approach could make a big difference too.
Huge difference. Yeah. So I mean, I've been helping them at times too because they operate out of our clinic as well, or at least for our region, and creating like a handbook.
Hmm.
Again, that's been like easily PDF searchable handbook. So really, that education they put on workshops, kind of like basic psychiatry for like the primary care docs. So
Mm-hmm.
which are wonderful, wonderful programs as like bringing that CL world to the
Yeah.
outpatient world as well.
If I can raise one other
Yeah.
program, of course, I have a vested interest in this, which I will disclose. Um, at University of California, Irvine, which is one of our partners, we have what's called the Train New Trainers program. This started 10 years ago at Davis, and the mission is to teach primary care clinicians, be it NPs, PAs, or physicians. There's an occasional specialty physician who participates, but it's primary care focused.
Yeah.
And it's a year-long course. I think the participants get 50 something CMEs for doing this. They have 2 trips to somewhere in Southern California where we have 2 days intensive CME twice a year. Then we offer um, curbsiding advice, group supervision, a series of noontime standard presentations that go the whole year. And they are encouraged. Basically, what you want to do is make us a more psychiatrically uh, knowledgeable and skilled primary care clinician.
Yeah.
But we retain, once they finish the program, they can email us down the road indefinitely with questions. And this kind of program, of course, it's somewhat personnel intensive and all that, but you see the point of it. I mean, the solution is to make primary care work better.
Yeah.
We can't treble the number of psychiatrists. Even if we could do that, we couldn't. that wouldn't work. You need to do it
Right.
the other way. So,
An interesting thought after I was reading this article was that the article is saying that post discharge failures are due to system issues.
mhm.
How do we balance system responsibility with patient like agency, autonomy, without slipping into like blame, saying like, "Oh, this is so and so's fault that something didn't work out."
Meaning, presumably the patient doesn't avail themselves of the help, and that's on
Correct.
them, if
Yeah.
you will. Okay.
Yeah. Yeah.
Well, I mean, there is a bit of that, but that's not most of it. I mean, I think
Right.
the solution in a constructed sort of way would involve a couple relatively straightforward ideas,
Hmm.
some of which we're actually doing here in Sacramento. For instance, we have two medicine, psychiatry, and family medicine psychiatry combined training programs, and then clinics to support them.
Yeah.
So the clinics populated by our group, what they take care of is folks with complex chronic medical illness and complex chronic psychiatric illness, sort of at a one location. Now, not every place can do that, but that's part of what we do. The second thing would be a greater intuitive alignment between psychiatry only outpatient models and primary care only outpatient models. Now, some places, including here, the county mechanism might run a primary care program and run a
Hmm.
psychiatry program. So those can be encouraged to be more, collaborative with each other. Is it optimum? No, but it could be optimized.
Yeah.
You know, I'm not convinced that the psychiatry outpatient clinics routinely want to know who the patient's primary care physician is, routinely collaborate to and fro. Um, and I think that needs to be done better.
Yeah. There is an aspect, especially when we're talking about outpatient psychiatry, and a lot of, outpatient psychiatrists are doing private practice, right? Where
Hmm.
they kind of fall into siloing, isolating themselves, and not reaching out as much as would be ideal, like as much would be available in a hospital system or a shared EMR kind of system where we're
Hmm.
like, oh yeah, they are seeing other people as well. There are other people that are involved in this patient's care.
Hmm.
Yeah, so that's something we want to look at.
Well, I mean, I agree with that. And I mean, what do we do with that? Well, one is what I would call more, if you will, enlightened primary care,
Hmm.
um, including structural elements, including common EMR,
Yeah.
including not labeling psychiatry notes as secret,
Yes.
making them open like any other consultation. Because I will tell you, and this may be controversial, and I really don't care if it is, excessive reliance on psychiatric secrecy itself encourages stigma. Remember, primary care doctors, they deal with, sexual matters, existential matters, all kinds of things. So to imply that they cannot understand psychiatric material is in fact a little insulting, and as if what we do is so fundamentally different that we can't communicate it to others. I think we need to all actively question that and encourage collaboration at a sort of a parallel level.
Yeah. Tell me more about that. So it seems like this is like a little, a kind of idea that's brewing a little bit, or there's a little bit more under the surface that, like,
Yeah.
again, I joke about it that like there's the psychiatric magic or the wizardry that we have, the psychiatric superpower that we have that allows us to do what we do, but
Yeah.
that like you other doctors don't understand what we do, right?
Well, yeah, there's a bit of that. Now, now, can you make the argument that certain kinds of psychotherapy models that's justified? Yes, I think you could justify that. So I'm
Yeah,
not, I'm not having issue with that exactly.
yeah,
But I'm saying most of what is done in clinical management, um, includes medication monitoring and things like that. I mean, you can even make a safety argument. Now, if a patient is being treated in a psychiatric clinic, let's say,
yeah,
with lithium and clozapine and things, and that note is made secret, and the patient shows up in the ED delirious and someone tries to figure that out, I might even have difficulty accessing that chart. And if I knew that data, I would immediately know what to do.
Right.
So it's actually a safety concern, and that's not trivial.
Right. I've seen it even with like other psychiatrist notes, where again in the shared EMR system, we're like, I'm not even able to access some of the notes at
Right.
times. And I was like, we're in the same field where,
Yes.
this is a referral that you've sent over to me and I can't access your notes to look at what's going on. And it's like,
Yes.
this is a little bit of a problem.
Well, and I think our field needs to, number one, confront that, and number two, see themselves as part of a broader continuum of care
Hmm.
involving team care at numerous levels.
Yeah.
Um, Again, it's easy, obviously intuitive for a CNL person to say that because we do it all
Yeah.
the time. But I think
Yeah.
there's an element of that that is part of this. It's not the whole thing, but I can't ignore it either.
Yeah. Speaking of like stigma, and I think a stigma is, this big, broad word and has a lot of
Hmm.
kind of stigma around the word stigma,
Yeah.
almost. But do you feel, or what kind of stigma have you maybe felt from peers in the field? Because I know maybe either towards patients or even towards yourself or within the field as a whole. Like I can remember stories, and I think they give a nice case example in the article was back reminded me of something in training where I was training at the VA. I had a consult at like 2 in the morning from surgery team, patient being called a difficult patient. Can you talk
Hmm.
to them? And I go over there and I'm saying like, hey, what's going on? And she's saying, you know, I don't want the surgeons touching me. And I was like, okay, can you tell me a little bit more about this? And what she what ended up saying is like, she had a history of, military sexual trauma and, you know, that was like in the chart, but again, not like highlighted as this something to what be watching out for.
Hmm.
They have med students coming in at like 4 or 5 in the morning to like do physical exams unannounced. And, you know, she's telling them to get out. And
Hmm.
surgery is like, why are you doing this? Why are you yelling at our students? And, refusing physical exams. And now you're a difficult patient and you have this label on you that gets
Hmm.
slapped on the patients. And then I'm seeing them at 2 in the morning and going back to the surgical team to be like, please ask permission and identify yourself
Right.
and like before announce what you're doing before just randomly touching people in the middle of the night.
Yeah. Well, I mean, that's a nice example because, you use the term trauma-informed care is becoming a little bit
Right.
more um, aware. I mean, why isn't all care trauma-informed care?
Right.
I mean, it's really what you should be doing anyway. It's just somewhat, I would say, accentuated in your example,
Yeah.
but it's valid very broadly.
Yeah.
So if we contribute to an appreciation of that more broadly, and that is happening, it's not always happening, to a pleasing degree, but I see much um, more awareness of such concerns among our physician colleagues than I would have 25 years ago. I will say that unequivocally.
Yeah.
Is it where it should be? No, probably not. But is there favorable momentum? Yeah, yes, there is.
Yeah. Do you come across any issues again, like with your medical colleagues, or about whether it's hesitation with reaching out to you, over reliance with reaching out to you, things like saying, "Oh, can you do capacity evaluations?" Because the unnecessary capacity evaluations, or along those lines.
Well, number one, we are the subject matter experts on decisional capacity.
Yeah.
So, like any other intervention, some are straightforward, and really
Mm.
anyone can and should do them. But some are not, and
Yeah.
that's the whole referral consultation threshold thing. So if other physicians truly need our help with that, I mean, we need to be uh, forward and available and kind of seek that out. My group wrote a decisional capacity review paper 2019, I believe it was, which is sort of a summary of the literature at the time and a what I thought was a very directive kind of how to approach if people told me they find that helpful. Um, so that's a significant part of consultation liaison business. It's something like a fifth to a sixth of all consultations are just that. But sometimes it's not just that.
Hmm.
Sometimes you encounter the decisional capacity question, and in course of working it up, ascertain the patient's got dementia and delirium, and that's a whole other problem.
Right.
I must say those of our colleagues who I think very regrettably will focus on only the decisional capacity question, not the reason it's impaired. They're not doing everything they could do.
Yeah.
So I would treat it like a chief complaint. Questionable decisional capacity requires a certain evaluation, and many times, of course, uh, intervention might improve the decisional capacity, and then the patient is in a better place. So that's my statement on decisional capacity. But it's an
Yeah.
important function. I mean, we need to
Yes.
completely
Yes.
own it. And if
Yep.
others can't do it, we shouldn't try to say, well, you should do it. If you can't, you can't. Call
Yeah.
us when you need it, but call us telling us what you have tried and what you have seen, because that's a starting
Yeah.
point for us.
Kind of wrapping up a little bit, but like, what is
Sure.
one thing that psychiatry could learn from the rest of medicine, and vice versa? One thing that medicine could learn from us.
Hmm. Boy, how much time do you have for that one? Well, taking your first condition first, I think we, in our own learning and our own development, we need to try to be as medically current as practical,
Yeah.
be aware of what's out there, know what patients are experiencing. That doesn't mean you have to be the providers of those things, but you should know about them. Uh, there's legion examples. I could go on and on. Psychiatric side effects of immunomodulators. You know, in CNL, you see this all the time. So,
Hmm.
complex organ transplant cases, complex cancer chemo, all of that. And
Yeah.
many of the side effects are purely psychiatric, and they look a whole lot like schizophrenia. Well, who's going to figure that out? That is our job to figure that out.
Right.
Um, Acceptance that psychiatric illness is on the spectrum of all medical illness. We should
Hmm.
not use terminology like medical versus psychiatric illness. There is illness. There are different
Yeah.
symptoms, but it's all illness. Um, what others could learn from us, so I hope they do learn from us, is take a more integrative approach, a
Yeah.
more, if you will, individual approach. Why does this particular patient have this particular difficulty right now? Well, that's because they have comorbid whatever they have. And again, that's another illness the patient has that has to be understood in both the psychiatry and the general medical side.
Yeah.
I mean, I would argue that's the role of CL is sort of to be the transduction object between those two areas.
Yeah. It's one of the things I always, when I have the residents, peds residents, and they're kind of shocked that I'm not just talking about Prozac and Zoloft all day long. I I ask them, or I tell them all the time, is to like reflect and say, is this a medicine problem or is this a
Hmm.
non-medicine problem? Like, what are the other things in the person's life that are going on and that
Right.
are contributing to why they're here in my office today?
Hmm.
And so I, again, like I think it's a very, very, very interesting field. I think it is a thing that we have to remember as psychiatrists too, is that like we're physicians first, right?
Hmm. Hmm.
And, again, like people talk about the DSM, well, they have criticisms, valid, invalid, whatever you want to say about it. But the one good thing is that it says cannot be better explained by a medical condition and or a substance, right? And
Yeah.
a lot of times we kind of overlook, forget that part of it.
I mean, I remember from my residency, one of my better residency instructors, and the terminology is now a little anachronistic, but what he would say to us all the time was, your first three diagnostic questions are organic, organic, and organic.
Yeah.
If there's nothing there, well, then you move on, but you always start there. And
Yeah.
certainly CNL people, I would say do that as a core mission.
Yeah. Last kind of question, and then we'll kind of wrap up. But like, what are some things that you do for yourself, for your own self care? Because those are very, very important things for all of us in the field.
I'm probably not the best model of that. Um, people ask me what's the work like. I say, well, I usually work half days, only 6 to 6. Um, what do I do? I try to maintain. I think it's helpful to maintain a sense of balance, such as having numerous activities. Even though I love being in the hospital, and I'm about to go over there, of course, I wouldn't want to do it every hour, every day. So I spend about maybe a fifth of the time doing TMS procedures, doing ECT and things like that.
Yeah.
Um, Consulting with outpatient systems, in being very involved in teaching nursing students, PA students, medical students, residents, and so doing that in a very purposeful way to encourage a balance. It's an enduring challenge. The current environment is extremely difficult, but not just for us, for everybody. And I think if we just empathically resonate with that, when I think about that very actively, I'm a lot less impatient with our ED colleagues
Yeah.
because I think of what they're up against, and you have to be respectful of that.
Yeah. Cool, cool, cool. Any kind of like parting words for listeners or anything you want to leave them with?
Well, thank you for the interview, first of all. Second, coming back to
Yeah.
this article, which again was unsolicited,
Yeah.
I think they did a very good job of this in terms of active consideration of the handoff to outpatient care. What kind of things need to be accomplished, all in the spirit of the patient doing their best and not ending up needing hospitalization too much. I think we all need to try to do what we can to avoid that. So I thank them for the submission. I told them that when I approved it some months ago. Thank you for paying so much attention to this nice article too. And I
Yeah.
hope others read it as well.
Yeah. Thank you so much, Dr. Bourgeois, for being able to fill on in and your time with us this morning.
Nice to meet you. Thanks, Michelle, for helping.